All right, so I'm Nora Kolnaski. I'm the certified wound nurse who works over at Northwestern Medical Center. I've been in this role for about 5 years, and just recently, in the last month or so, in addition to working on the primarily the inpatient side, doing the inpatient floor and trips to the emergency room. Oh,
Yeah.
We have established a kind of a temporary position to allow me to start slowly seeing some people in the outpatient setting, primarily in the primary care setting in the Franklin County area. And so as a part of that kind of new role, we're also offering these educational sessions. So that's how this kind of came to be. And so what we've been told is that there's a lot of interest in learning about Xylazine wound care in our community. And so that's kind of how this topic was brought to me. And I'm happy to do this, but I also just want to provide some full disclosure, which is that I am no expert on Xylazine wounds. I do see them in the hospital setting. I don't see a high volume, but I have worked with a handful of folks with these, both in the emergency room and on the inpatient floor. Sometimes they're admitted for those wounds, maybe an associated infection, and sometimes they're admitted for reasons that have nothing to do with the wounds, and I'm seeing them for their wounds anyway. So I just kind of wanted to throw that disclosure out there, and then also just offer, there's going to be, hopefully we'll have time for a Q&A session at the end. And so I just encourage any of you who maybe have more exposure to these wounds than I do and have any kind of tips or tricks or anything that you want to offer to not hesitate to speak up, because it's kind of been, I think, a new learning curve for everyone in the medical field these last few years. So as it pertains to kind of like what we're doing today, we're going to just keep this really basic. We're not going to go, too deep into this. So we're looking to help you identify if there's a wound you're looking at that is related to Xylazine use. And then certainly being able to recognize whether the wound shows signs or symptoms of infection. A real basic understanding of how to dress these wounds to help people kind of dress them themselves, and then have an understanding of knowing when to recommend for a higher level of care. So what is Xylazine? Xylazine is being added to illicit fentanyl and heroin. It has been, I think, over the last like 3 years or so. It's kind of ramped up. What it's for is for analgesia and sedation in animals that are being taken care of by vets. It's a tranquilizer. And so kind of side effects that can come from this happening or being ingested in a human body is a localized vasoconstriction of the vessels, which ultimately leads to decreased perfusion, decreased blood flow, causes a painful skin ulceration, and then it, opens up into a wound and puts the person at risk for an infection. So as it pertains to wound care for this type of wounds, I mean, this is all new. So we're kind of, everyone in wound care has kind of just been rolling with it as we've started to see more cases. And like I said, here in the St. Albans area, I personally have not seen a high volume. I know that Burlington certainly has, and then, bigger cities like Philly, out in Colorado, California, they're seeing a lot more. And so there is no actual like hard evidence based data or guidelines right now on how to specifically treat a Xylazine wound. And so, those of us working in wound care kind of just use the basic principles of wound healing in order to meet the needs. But another big piece of this type of wound care is really taking into account this population, right? So they're going to have a whole nother set of needs that we have to take into account when forming a treatment plan. So, Do they have stable housing? If they do, does that housing have heat and running water? Do they have access to medical care? Are they willing to seek access to medical care? Have they had bad experiences in the past with getting medical care? And so they are adamant about avoiding it. Do they have transportation? Do they have health insurance? All these other things. And so these have a direct impact on how we're going to treat these folks. As it pertains to the wounds themselves, kind of characteristics of this type of wound, it's important to recognize that wounds from xylazine use, number one, can happen anywhere on the body, not just at an site and injection. But number two, the person does not even need to be using drugs via an injection to get wounds from xylazine. So I can't stress that enough. Just because they have wounds on their body, and that those wounds may indeed be a side effect of the xylazine, they may not be using intravenously. It doesn't have to be through an IV, which that was a learning experience for me. I didn't realize that, but it is associated with illicit drug use, of course. Most frequently, I have seen them on kind of like the arms and legs, but they do develop in other areas like the trunk, sometimes even the face. There's kind of different stages that they'll go through. So they might start off looking like a small blister. It might scab over, or they might be these tiny little holes. And then they can gradually get larger and turn into larger open wounds. And if those wounds aren't well cared for, then the skin might start to kind of die or get really crusted over. And so they can range from like something pretty mild looking and relatively shallow to something much more severe and quite either thick or deep. There could be exposed muscle, bone, tendon, and they can progress quite rapidly. Because again, if you think back to that mention of what the drug does, it causes vasoconstriction. So it's limiting blood flow. So when you don't have blood flow, you're going to have increased damage over time, especially if you're having repetitive exposure to this drug. So this is just a nice little visual that the Department of Health in Philadelphia has related to xylazine wounds. And so the top arm kind of shows what the skin might look like in the early stages of wound development. And then the middle is kind of like the middle stages. And then the bottom shows a more advanced ulcer with more like the dark tissue is like dead necrotic tissue. If anyone has any burning questions as I go, please don't hesitate to reach out. And I do, obviously apologize. We're going into some graphic wounds here, so just kind of a heads up. But so these are some more real life pictures of xylazine related wounds. This is a finger. We've got two different wound beds going on. You've got kind of like a dark black, relatively stable, dry ulcer, and then you have an open wound on the other finger. The open wound over here has got kind of a lot of gunky, fibrinous, unhealthy tissue, and then with some good wound care, we were able to clean it up. There's some tendon exposed under here, but again, we can get it to some healthy granulation tissue with good wound care. These are photos from another wound care clinic in a different state, but again, showing the progression of xylazine wounds. And so there can be this like real similarity to that of like a burn almost. And this person's arm kind of shows that. And so you really, it starts off this kind of like relatively small thing, but then again, with that vasoconstriction, poor blood flow, it really progresses. And so all that black tissue is obviously dead. And so that needs to be totally sharply debrided off in an OR in order to get it back to this kind of healthy state. So this is a more severe case. Some more photos. This is kind of how they can look on a foot. This is an example of about like plus or minus 5 days from start to 5 days later. So kind of like what we've already talked about, a little bit almost like a blister looking type appearance. And then with time, it starts to kind of dry out more and show more non-viable tissue. These are some leg wounds. Again, just multiple spots on legs is common. Another foot ulcer. Um, and just this kind of a nice little graphic because it just kind of shows, um, what's going on in the tissue. So over here, it can look like a blister, and then this is when you can get kind of like the dead tissue, kind of that crusted tissue that forms over it. And then sometimes, there's a deeper aspect to it, and then you get some kind of gunky yellow dead tissue that forms within the ulcer itself. And so these are all kind of pretty similar characteristics of what we've been seeing. So pretty basic, but quite important things to just keep in mind in terms of what are the signs and symptoms of infection when you're looking at wounds like this. Any kind of purulence. And so I see this a lot. I see this in healthcare a lot, is that sometimes we're quick to think that something is infected, and obviously, if it is, we don't want to play games. We want to get them treated. And so, you're never wrong to send someone to get seen by a medical personnel if there's ever any concern for a potential infection. Sometimes the wound just needs a real good clean, though. If there's kind of like some gunky, non-viable tissue in the wound bed, it can cause this drainage that's kind of like yellow looking. It might not actually be pus, but it can cause like this kind of like gunky yellowish color. So you're really looking for like multiple signs to point you in the direction of an infection, and that is also a lot of redness around the wound. Sorry, something.
I asked everybody to share their email. Now it's going to be dinging on you while you're speaking. So I was going to see if I could mute it somehow.
Oh,
or maybe just hold your emails till the end of the presentation.
Okay. And so in addition to pus, to redness, swelling, if there's a strong odor, oftentimes, you're taking down, like if you're taking down an old bandage, there is going to be an odor. So don't just assume that it's infected because there's an odor. Clean the wound first and then see if that odor is kind of lingering. If there's any kind of change to the firmness of the skin around the wound. In addition to redness and swelling, the skin's often really hot. You can feel that heat when you touch it. And then certainly if the person is exhibiting more symptoms like a fever, if it's extremely painful, if having like nausea, vomiting, that type of thing, then certainly you're looking at a potential infection. So what do we do about these wounds, right? And so again, kind of like what I said at the beginning, first of all, in wound care, there's always a million different choices. And so it can be hard to know what to pick, but it really depends on the patient's situation. When I see these folks in the hospital setting, I kind of just talk to them about it and find out a better understanding of what their living situation looks like. How motivated are they to be involved in their wound care? Because ultimately, they're gonna need to help take care of it. And so talking to them is really the biggest way that I determine what I'm going to do for their wounds. It starts with a conversation, and also obviously an assessment of their wounds. But if their situation is relatively unreliable, meaning we don't know about their housing situation, we don't know how motivated they really are to really do perform good wound care to their wounds. We're not sure if they're going to continue to actively use, if they're able to understand the steps to doing wound care or have someone help them do the wound care. Because again, not only doing it, but then providing them with the supplies. So there's a kind of a lot of moving pieces to this. So if we're trying to keep this like as basic as possible, then you're going to go with washing your hands, cleaning the wound with whatever you got, whether that be a normal saline or any other kind of wound cleanser. And if you don't have access to either of those, then soap and water can be used. The number one recommendation is to stay away from alcohol and hydrogen peroxide because that will dry everything up and can kind of cause more problems. So you don't need to go that route. And then again, when we're keeping things basic wound care can be an A&D ointment or like a Vaseline type petroleum jelly or even a bacitracin type application, and then gauze. And then you can wrap that gauze with a gauze wrap and kind of tape it. Make sure it's not wrapped too tight. You can put an ace bandage over that if you want to kind of keep the gauze itself clean and intact. But again, make sure the base is not too tight. And then if you're doing something really simple like this, it should be done daily. And so if we're gonna really kind of meet the patient where they're at, and we're gonna keep things simple, this is really as simple as you can get. We are going to dive into more elaborate options, but if those are not realistic, whether it be for access to supplies, the patient's own personal situation, being able to handle the steps to that type of wound care, or any other barriers, then don't worry about it and just stick with this basic steps. So this is kind of a wordy slide, but basically, this kind of is like scenario 2. If the person can carry out more detailed steps for caring for their wounds and or get some consistent help or follow-up to keep these wounds kind of monitored, then maybe you can look into doing a little bit more than what the previous slide said. And so when it comes to, again, basic wound care steps, you're going to want to think about the skin around the wounds and protecting the skin around the wounds with a product that can prevent any kind of maceration from drainage. And so I think a lot of people are familiar with skin prep. Skin prep can do that, or any kind of like barrier paste or ointment can be done to really protect the skin around the wound, especially if the wound is heavily draining, so that drainage isn't sitting on the healthy skin around the wound, macerating it further and making the wound ultimately bigger with time. If a wound is opposite of highly draining and is actually like quite dried out, scabbed over, couple things you can do. Technically, if you have someone with what's a stable and dry intact scab, and this patient is motivated and willing to do wound care and heal this, then you're going to want to put something on that dry tissue and that scab to kind of moisten it up and help it off, because that dried scabby tissue is actually not healthy. And so that can be done with like a Meta Honey or a hydrogel, and you just apply that directly over the dry tissue, and then you still have to cover it with a dry dressing, whether that be, again, keeping it simple, and a gauze, ABD pad, a kind of foam, or even a large Band-Aid. If it's something that doesn't have an adhesive, then you need to wrap it to kind of hold it in place. And you're going to do that daily until the dry tissue moistens up enough where it comes off with cleaning. And then you can switch over to another dressing once that scabby dry tissue comes off. Wounds that are draining and have kind of a moist wound bed, there's all different kinds of things that you can put on the wound. Depends what you have access to, but any kind of calcium alginate hydrofiber or foam dressing that can be cut, it doesn't matter the brand, you can cut it, put it directly on the wound. Know that any kind of silver version of these, it would have the letters AG in it, provides kind of like an antimicrobial effect to the wound bed. And so that's nice when you have the ability to do that in this population. And then you're still going to need a dressing over that to kind of hold it in place. And again, kind of the same options. And then these last notes just say, any kind of wound with depth, the goal is to fill that depth with one of the dressings that are listed above. And then all of these wounds have a need for like a first dressing and then a second dressing. So the first is called primary. That's whatever you're putting directly on the wound bed. And then a second is called a secondary, and that's to hold it in place. And so this is like real skimmed over short version of basic wound care. And I don't know what all of you do, and so I don't know how if this is too much information or not enough, but I'm trying to kind of just keep it simple and straightforward. I will say that when I am working with these folks and I go into their room and I assess their wounds and I talk to them about what their situation is, and I'm looking at what they've got going on their bodies. If they have a lot of areas that are these like dried out scabs, if these scabs are totally dry, they're not oozing, there's no like little bits of weeping coming through, they're completely dry, they're stable, they're intact. Stable meaning they're not soft and mushy. There's no signs of infection or redness to the skin around it. They are stable, dry, and intact, crusted over scabs. I talk to the patient and I say, if you want these wounds to heal, because right now you have all these scabs, and technically that's not healthy, intact tissue. So if you want your skin to be healthy and intact, we can provide wound care to these areas that are scabbed over. But what that means is, as soon as we moisten up this scabby, crusted tissue, we're going to create an open wound on your body that probably will be draining. And so then you will absolutely need to keep it cleaned and covered, or it will get infected. And so would you like me to do that? I can help you get this started on the road to healing. We can moisten up this scabby tissue, open this up, and let it heal the right way with new tissue growth. And I can give you instructions and supplies, and you're going to have to continue to take good care of this. Or sometimes that is just way too much, way too overwhelming, and they want nothing to do with that. And so leaving a dry, stable, intact scab alone is okay too. So it all depends on kind of like who this person is and what they're looking for. Because again, you know, I've had people who are carrying on a full-time job and they have a good stable home and they have you know, and they're very reliable and they happen to be, you know, using fentanyl and are getting exposed to xylazine and have wounds that they need to take care of, but are very much motivated and interested and able to care for their wounds. So that's going to look a little different than someone who is not. So this is just kind of like a real quick chart of kind of like breaking it down between a dry wound, a wet and draining wound, or somewhere in the middle that's moist. And then the size. Are they shallow? Are they deep? Are they, this is getting into more severe categories. Do they have tunnels? Meaning you get a Q-tip in there and it goes quite deep. Is there exposed muscle, tendon, bone? And then what is the extent of dead tissue? And then kind of like condensing what you can do. This is just basically a repeat of the slides we just talked about, just in a different way to visualize it. So when you have a wound that has a lot of depth to it, especially if there's a tunnel or undermined tissue, means there's space under the edges that you can't see, but it's there under the edges of the wound all around. Ideally, after a good clean, those wounds are going to be packed and all that space is going to be filled. Because if you don't do that and you just cover it, you're leaving all that open tissue exposed, and it's not going to fill in properly. And so the best way to like get new tissue to regenerate and grow the right way is to pack it with a proper wound product. Now, if you're packing a lot of space, you really want to make sure that you're just, well, regardless, whenever you're packing, you want to try to use just one long piece of packing material so that with a nice tail sticking out, so it's quite easy to just remove with the next dressing change, and you're not putting the patient at risk for having like little pieces of packing stuck in their wound and God forbid left in there. Certainly, if there's any kind of wound with muscle, tendon, or bone exposed, they need to be seen by a medical provider. So that's what I just said. If the pain is extremely severe, if they're unable to move the body part where the wound is located, if there's a lot of dead skin coming off, and then any signs of infection. Those are all reasons to seek medical attention. Sorry, this I just can't really see. So other pieces of information. So I do feel like I've gotten more comfortable in identifying wounds that are related to xylazine. You know, obviously the biggest thing is establishing a relationship with this person so that they feel comfortable enough to talk to you about it, and they can open up to you as to whether they have, if they are aware that they've been exposed to xylazine or not. Because sometimes they might be using drugs that are not opiates, they're not fentanyl or heroin, maybe they're using like crack or cocaine. And I've been told that xylazine can sometimes be cut into those drugs. I am not an expert, I don't know. But so having xylazine in their system may or may not be surprising to them. And I do know that there are test kits out there too. I've heard that they're not always super reliable, and I don't know how much they're being accessed. But there's other things that can cause wounds in this population of people who are using illicit drugs. And so that might just be the form of injection. If they're doing their injection in a poor way and they're damaging their veins, if they're using needles that are dull or needles that are too big, or they're reusing needles, or they're sharing or trading needles, all those things. Injecting at the same site, time and time again does cause trauma to the area and scarring to the area. And then how long have they been injecting? Like if this is something that's been a habit that's been years and years and years, they're likely to have more severe damage as a result. And then obviously, you know, if they're dealing with other chronic comorbidities, if like in addition to drug use, they also have diabetes, and if that diabetes is not well managed, that's going to play a part in their wound healing. And again, if folks have been injecting for a long period of time, and if they've been injecting in the lower like leg and foot area, they're more likely to have a mixed venous disease too. And so there can be a lot of things kind of happening all at once. And so just some extra kind of points on all of this. So sometimes we're doing harm reduction in these cases. It's really just a matter of finding out where the patient is and meeting them where they're at. Obviously, it requires a lot of compassion. There's a lot of people who have had poor experiences in the healthcare world as a result of their drug use. And so they're going to come in scared and sometimes not really willing to engage. And so it requires showing them that we're here to help. And once you've established that kind of relationship and comfort level with them, then you can find that you're likely to get more questions answered and get an actual history so you can provide the care that you need to. So, and I kind of mentioned this already, if they've been injecting in the groins, legs, or feet, they are likely to have a venous disease if that's something they've been doing for years and years and years. And so that might mean they need compression in addition to wound care. And if they smoke cigarettes or long-term cigarette smoker, they might have issues with their arterial blood flow. And so just knowing that there's a lot of different things that can cause wounds, especially if the wounds are on the feet and the legs. And so it doesn't necessarily mean that they are using IV or they've even been exposed to xylazine. You might be looking at vascular wounds. If it's not something that you do day in and day out and you're not as familiar with wound etiology, it's definitely best to not assume that what you're looking at is xylazine related, because it certainly might not be. There's a lot of different causes. So there are some resources out there, like I said, bigger cities who have been seeing a higher influx of this than us have created some of the information that I used in today's little educational PowerPoint that you've been looking at, these are some of the resources of like the fact sheets and kind of like wound care triage type things. It just reiterates basically everything that we've talked about. And that is all I've got. And so I'm happy to open the floor up to questions or comments.
There was one question already in the chat from David asking, what is the mechanism for involvement of remote sites rather than injection sites?
What is the mechanism for involvement of remote sites rather than injection sites? Oh, so like when wounds develop on the skin in an area that the person was not injecting, you mean?
I'm curious about that too.
Yeah, so again, my limited, I'll admit, my limited understanding is that when xylazine enters the body, the human body it basically rejects it. And so, and for some reason, it finds a way to, through the vasoconstriction at whatever site you're seeing, kind of like push it out through the skin. And so I don't know if there's a rhyme or reason as to why it develops on the various parts of the body that it develops. Because again, it's not always being ingested or entered into the body through the bloodstream. And so it still can just take place. And so I don't know if it has to do with the way the blood is flowing, and we're more likely to have kind of a vasoconstriction response in the extremities because it's like further away from the heart. And so if that's why, I'm not exactly sure down to the nitty gritty as the exact reason for why it evolves where. But I do know, because I've seen it, that it is not necessarily directly related to where the injection site is. Yeah. Time frame. A single xylazine injection can continue to manifest skin changes on the wound. I don't. I would imagine it has to do with the volume of xylazine that entered the body during that single injection. And in terms of, how long it takes the xylazine to leave the body, it can still have these like lingering effects, I would imagine, because once you have that skin damage kind of get initiated, once that happens, it can evolve from there. And so you can continue to see involvement long after that injection use. But in terms of more wounds popping up long after, I wouldn't think should be a problem if it was truly just one single use. But please, like I said, if any of you who are in attendance are seeing more of these wounds and have any other answers to questions to offer, don't hesitate to speak up, because we're all kind of in this together.
So I work at Champlain Housing Trust. So I work with a lot of, sorry, can you hear me?
We can hear you. Yep.
Okay, great. So I work with a lot of residents who we have like a lot of trust stuff with what's going on. So I have a lot of residents in buildings who will all then report to me that they have MRSA or some other type of staph infection going on, where there's like concern of this kind of that it's contagious versus use. So I'm just wondering if this is like common, if other people are running into that, if it's can turn into some kind of staph infection.
My guess is this is more related to like history of MRSA, is maybe what they're talking about, if this is something that they have a history of versus an active infection. I'm not sure. It would depend on what the patient is saying and how they're presenting, but
Yeah.
because
So it'd be like a whole building or like a very common like number of units, right, who are I'm working with, and we have concern, and then they all have open wounds. We are talking about that kind of thing, and it's like we were scared to go into any kind of healthcare thing, but they're like, this is MRSA, like it's going around the building, and everyone has it. So I'm just.
Do you have anyone who like works with an infection control specialist and to help with that? That sounds like that would be something that would require someone in infection control if it's in a like a residential. Is this like
Yeah.
what type of resident building? Is it like a
So it would be
healthcare?
just no. So it's just like tax credit or apartments. So
Oh, okay.
yeah, so like I work with a range of households who may present in different needs.
Okay.
And then when I'm working with each of them, it's like that's what it's presented as instead when we're like concerned about like wounds and things going on. And it's like you can't come in. There's so yeah.
Okay. Well, I think it would be a matter of, getting each like a full history from each patient in terms of, what their symptoms are, not only what any kind of wound looks like, but if they've been having any other systemic like in symptoms, excuse me. And if they do have a draining wound and you're concerned about like exposure to you know, technically, like a contact type PPE, like a gown and gloves are generally what we use along with practicing good hand hygiene, are enough to kind of protect yourself.
Yeah.
And then in terms of like the person's symptoms and how severe they are and needing to be referred to, whether it be urgent care, if they have a primary care provider, to just to better look into that. Sometimes people have like a history of MRSA, and that might be confusing for them moving forward, or versus something that's active.
Right. Interesting. Okay. Um so when I'm doing like research, somebody saying they're having MRSA that's being spread, this is open wounds is different for like contagious versus something like a staph infection, right? Like these are
Right. So if certainly anything that's draining you, we would want it to be kept clean and covered so that
yeah.
that drainage isn't getting, all over the place. And so as long as that's happening, then it should be okay, as long as things are being kept clean and covered. And if a dressing is getting saturated, it's getting changed um and contained in that way.
Okay.
Yeah.
I have a lot of people currently who just like really don't want to go to get help at all, or things looked
Yeah.
at. So yeah.
Yeah. Well, that's another thing we can look into. Certainly I'm no infection control expert, but in terms of better understanding ways to help people like you who are out in the community, helping people who don't want to come in to be seen, to, I don't know, better understand what to look for, I guess, and just to help you feel more comfortable in being out there. It's maybe another topic we can look into.
Thank you.
Yeah.
Are there any other symptoms of xylazine use that we should be aware of, just to be picking up on that would point to that kind of thing?
I can't think of anything specific to xylazine, exactly. Like, I think when you are thinking about whether they're being exposed to illicit drugs, there's other things you can look at in terms of, I guess, well, for me, looking at the skin in general in terms of, not just hygiene, but like, taking good care of it and, talking to them about uh, what they feel like they've been exposed to. Oftentimes, I feel like most people are willing to talk to you about what they're using. And so a lot of times I find folks are pretty forthcoming about using crack and cocaine and are in maybe like a medication assisted treatment for their opioid use disorder and don't think that they've been exposed to any opiates, for a number of years. And so then it's a matter of, are what you looking at wounds related to the crack cocaine use, to IV drug use, or is there any potential that xylazine has been mixed into those? I truly don't know if that is something that's happening, but the more you can talk to the person, the more you're going to be able to find out.
I wonder if they even know sometimes if it's in there.
Well, they might not. Yeah, they might not. Yeah.
What would
And
be
so,
like a difference between like a cocaine type of presenting wound and a xylazine?
well, if they haven't been exposed to xylazine, then the wounds are going to be more related specifically to IV drug use and be at the location of the injection. Because just using cocaine doesn't cause a wound. It would be injecting it. So that would be a big difference. Yeah.
You mentioned the xylazine test strips, and I don't know, Nora, if you're familiar with them, but is that like a urine dip test strip? Is that, how are we?
I think so, because what
Okay.
I was told was that BART, I think,
Yeah. I've
or
heard.
that,
Yeah, but
because
I think they
we've,
have some
yeah,
too.
we always were handing out fentanyl test strips. And then
Yeah.
my understanding is that they more recently came out with the xylazine ones as well. But I've
Mhm.
also heard that they're not super reliable.
Yeah. Actually, Sarah Hull just put her hand up and I wonder if she might have some insight on that too.
Yeah, go ahead.
So the test strips, they can be used to test urine, but they're actually meant more to test the supply itself.
Oh, okay.
And they can, if they're testing, say, cocaine, they can get a false positive from the lidocaine that's also usually mixed in with the cocaine. Cora had sent out some really great instructions about what to do if you test positive. It's often a false positive. It doesn't necessarily, I know somebody had mentioned something about the reliability of the tests. If you dilute your sample a little bit more and then use a fresh strip and it's still positive, it's likely a true positive xylazine test.
Okay.
But after the first, it is likely a false positive. So it's really important to have them test twice. But those test strips are now coming in the harm reduction bags from the state of Vermont. We have them in our office, CVOEO, Samaritan House, pretty much anywhere. And anybody can come in off the street and grab those. But the bags do include both fentanyl and xylazine. But we have used them to test urine in the office, just to compare them to our test as well, that gets sent out to the lab. And they've been pretty accurate, actually.
Good. Oh, good. That's
Yeah.
great. Okay. Thank you for that.
Sure.
Nick, I see you have your hand up.
Yes, thank you, Sarah, for explaining. Yeah, BART programs also distributes the xylazine tests to patients as well. We haven't actually received a lot of feedback or results from patients, but we give them directly to our folks who request them.
Great. Yeah, that's helpful. And I've heard that maybe this whole xylazine related wound problem is kind of on the downslide. I don't know if that's accurate, but hopefully maybe this will start to become less of such a huge problem soon. But does anyone have anything else? Okay, well, if no one has anything else, then I guess we can close out. If you think of anything after the fact, don't hesitate to reach out. And thank you all for coming.
Thank you. We will be distributing this recording as well. And if you do have another topic that I know we talked about, maybe a staff or an MRSA, is it Mercer or MRSA? I'm not clinical. How do you say it?
Either,
Doesn't matter.
yeah.
Either way, we can definitely look into including those in our next topic. So thank you all.
Thank you. Bye-bye.